welcome Dr. Michael Hehir. He is a neurologist at the University of Vermont Medical Center and an associate professor at the Larner College of Medicine at UVM in Burlington, Vermont. In 2016, he was funded through a 3-year Clinician Scientist Development Award in Myasthenia Gravis and related disorders of the neuromuscular junction from the American Academy of Neurology, American Brain Foundation, and Myasthenia Gravis Foundation of America. The study involved creation of metric, a mode of currency that Hehir can apply to various side effects from different medications in order to compare medications equitably. And to just kind of expound on that and to talk about, what does cause side effects, I would like to welcome Dr. Michael Hehir to our talk.
It's really nice to be here. And I know that there's been some discussion about treatments and other things with some of my colleagues earlier today. And I guess I'm just going to start my talk saying that this is going to be something I think completely different. Just a few things. So just my disclosures real quick. So I do consult for a few companies that make medications to treat patients with myasthenia. And I'm going to be discussing a little bit about some research that I've been doing and measuring the burden of side effects. And I'm just going to put up a little outline of things that I'm going to talk about today. So thank you again for coming. We're going to talk very quickly about how I think about the classification of the condition that is myasthenia gravis, a little bit about goals of care, and then we're going to talk a little bit about treatments and the current landscape and things that are coming, which I think you've already had a talk on today. And then we're going to talk a lot about understanding adverse event burden and what that means. We're going to talk a little bit about remission and medication reduction, and I'll raise some questions that I think are unanswered that are going to need to be answered for people as we move forward. So just quickly, as you all know, myasthenia gravis is one of the most common autoimmune disorders, and it is a disease of the neuromuscular junction, which causes a very specific pattern of weakness that we expect, involving muscles of the face, including the eyes, and sometimes muscles of chewing and swallowing, sometimes neck flexion muscles more than neck extensor muscles, and then shoulders and hips more than other muscles. A lot of times when we're categorizing patients these days, there's a number of different ways that we think about patients when we're thinking, and it's all relevant to the treatments and the expected course of illness. So one way we classify patients is whether or not they have measurable antibodies that are consistent with myasthenia, and which antibodies they are, because those are relevant. The most common antibodies are the acetylcholine receptor binding antibody, as you know. But there's also the MuSK antibody, and there's some newer antibodies that are sometimes measured. And then some people can have myasthenia and have no measurable antibodies in blood, which is called seronegative. The other way we sort of classify things is based on where the weakness is in patients. So a lot of patients will have weakness that remains just in the eyes and eyelids. Other patients will have weakness that extends outside the eyes and eyelids to involve other muscles in the body, as I showed you. Sometimes we talk these days about this classification of refractory myasthenia, where people are not responding to the typical treatments. We also talk about whether or not people have pathology in their thymus gland, and how old they are when the disease starts. These are all things that are sort of relevant to trying to figure out what the best course of action is. And when we're thinking about goals of care, my mentor is Ted Burns at the University of Virginia, who's done a lot of work in myasthenia. And this is kind of what he thinks of when thinking about the goals of care for pretty much any condition, but the paper that he wrote was specific to neurology. And when we're thinking about patients, we want to keep people safe. a lot of neurological illnesses threaten things that make us who we are and cause weakness or cause cognitive dysfunction and other things. So we want to help people do the things they want to do for as long as they can do them. We want to limit symptoms, and at the same time, we want to limit the adverse effects of these treatments for the symptoms. And we want to minimize the effect of conditions on quality of life and give people a better future. The Myasthenia Gravis Foundation, they convened a task force. You heard from Dr. Narayana Swamy earlier today. And the international consensus guidelines for the management of patients with myasthenia talk about goals of care. And the goal is to get people in a state where they have as few symptoms as possible, which on a research scale is called minimal manifestations. And people want to do that with the most restricted amount of adverse events as possible. And one way to measure adverse events is with a research scale that's used a lot in cancer research called the CTCAE. And that's kind of where we are in 2021. We're thinking about goals of care, and obviously it's important to discuss each particular patient's views on their goals of care. That's an important conversation that I have with everybody that I see in our myasthenia clinic. And when we're having these conversations, what we're really talking about is what are the treatments that are available now, and what are the treatments that may be available a year from now, 2 years from now, 5 years from now. In 2021, it's actually quite incredible. So I finished my neurology training about 13 years ago, and we didn't have this many options for patients with myasthenia back then. And now there are a lot of options for treating patients. And we have, when I think about the medicines that we use for myasthenia, I think about what they are, how they work, and how quickly they work. So we have, sorry, my mouse is very sensitive. We have medications that work very quickly, but are just symptomatic strategies. And those are the acetylcholinesterase inhibitors. And pyridostigmine or mestinon is the most common one that people use. And those can work on the order of hours, but it also wears off on the order of hours. For many patients, because this is an immune system condition, they require treatments that will quiet down the immune system response and allow the muscles to heal and function better. Medicines that work quickly in myasthenia, we really have three that are sort of tried and true. So we have corticosteroids, which is prednisone is the most common, or methylprednisolone is the other one that is often used. And that can work on the order of days to weeks. It's really more like weeks. And then we have medicines that are often reserved for emergency care. So we have plasma exchange, which is called apheresis on this slide. And we have IVIG, which again works on the order of weeks. These two treatments, plasma exchange and IVIG, they tend to wear off over 6 or 8 weeks. Then we have some newer medicines that we're using that may be working a little bit earlier. So we have the new medicine that's been out for a few years now called eculizumab or Solaris that's approved, and that works on the order of weeks to months probably. A lot of patients get treated with a medication called rituximab, which again probably works on the order of months. And then we have some medicines that we've been using for a very long time, which are called immunosuppressants on this slide. And these are oral medicines, and we're talking about medicines like azathioprine, which is also called Imuran, cyclosporin, mycophenolate, which is also called Cellcept, tacrolimus, methotrexate, and those medicines probably work on the order of months to up to a year. So for mycophenolate and azathioprine, in the studies of those medications, they took 12 to 14 months in some patients to become effective. And then I've also highlighted in green on this slide. So antibody status is important when you're thinking about treatments for patients with myasthenia. And they're in musk myasthenia, which is a very small subset of patients with myasthenia. The medicines don't work the same as patients who have acetylcholine receptor myasthenia. So the medicines that are most effective for these patients are steroids, plasma exchange, and rituximab. And rituximab's probably becoming more of a first-line treatment for patients with musk myasthenia. We also have a lot of medicines that are sort of in the pipeline, for myasthenia. The furthest along in the pipeline is the first medicine here called efgartigimod, which is a novel concept medicine, which causes the body to sort of get rid of antibodies on its own. It's an infusion-based therapy. And that medicine is going up before the FDA, I believe, in December. There are a few other medicines that are under development that use that same strategy. There are two other medicines, one called ravulizumab and one called zilucoplan, which are complement inhibitors that work similarly to Soliris. And then there's some others that are a little bit less far along down here. And on my timeline here, these medicines are likely to fall in the weeks to months range there. And then the other treatment that sometimes is used is thymectomy, which is a surgical treatment that can take months to years to really become effective. And when I'm sitting with my patients, this is kind of how I feel. So this is, I'm in Vermont, and we're known for our craft beers, and this is the craft beer section at one of our local supermarkets. And it's just sort of overwhelming to look at this case. There's so many choices, or which tools should I use for the job of all these tools that work similarly but are of different sizes and shapes. So I often feel a little bit like this. And I think probably for a lot of my patients, they feel like they're drinking from a fire hose when they're presented with the number of options for treatments these days. And it can be a bit overwhelming. And one of the things that's hard when you're making a decision among these different medicines is that when we think about the efficacy of these medicines, how well do they control the symptoms of myasthenia, a lot of them work very similarly in that regard. They're sort of equally successful at improving the strength for patients. Sometimes you have to find the right medicine for the right patient to improve their strength. But if you look at large populations of patients with all these medicines, they seem to have a similar efficacy. So that is where the treatment decision becomes a little bit more challenging. So a lot of times in the traditional way, when we're thinking about what is the value of a particular treatment for a patient, or a value of a particular treatment for a population of patients, we're usually thinking traditionally about the top part of this equation. We think about, sorry, my cat just walked through. We think about clinical benefit, which is how strong can you make a patient? How many symptoms can you get rid of? And then we think about patient quality of life. So does this treatment sort of improve people's overall, interaction with life on a daily basis? What doesn't come into the traditional discussions of therapies is sort of the bottom part of this equation is often not part of the traditional conversation. I think side effects of medicines is, but I think increasingly, as there's more options for patients, this part of the equation becomes the thing that will likely distinguish among the treatments long term. So we think about benefit and quality of life being the things that we're trying to improve, but then we also want to minimize the things on the bottom of this equation. So we want to minimize how much things cost, financially cost. We want to minimize side effects because those are going to contribute to taking away people's quality of life if they're having a lot of side effects. And then the other thing that we want to consider is treatment burden. So, and what I mean by treatment burden is it harder to sort of take a pill, or is it harder to come in once a week for an infusion that may last for 4 to 6 hours? So how much of that treatment burden is somebody willing to sort of put up with to get the degree of benefit and improvements in their quality of, or improvement in their strength. And this part of the equation is really where I'm going to focus the majority of my talk today, and particularly on adverse events, which I use interchangeably with side effects, is really what we're talking about. I'm not really going to talk about financial cost of medicines today, and I'm also not really going to talk very much about treatment burden. So I think it's really important to sort of understand adverse event burden or side effect burden. So we surveyed a really large group of patients with myasthenia a couple of years ago. Maybe even some of you filled out the survey. And we asked people, do you have concerns about long-term immune system treatments for myasthenia? And we asked physicians the same question. And you can see that long-term complications of medicines is important to patients. So 85% of people said that they had concerns, and 100% of the physicians were concerned. And if there were concerns, the things that really were first and foremost in people's minds was side effects on both sides, patients and doctors. The thing that they're concerned about is the side effects of the treatments that we're providing. Lower down on that list was financial cost and treatment burden, and the lowest was that the treatment would be ineffective. And I think that's because a lot of the patients that we were surveying were on treatments that were probably working. And then it just sort of, I think, emphasizes that the bottom part of this equation is really important when we're thinking about what we should be doing for any particular person. And adverse event, this is a funny cartoon. So this guy is saying, publicly, we're still saying there are no side effects. And these are all the people that are on the treatment. Side effects are important. So they cost a lot of money every year dealing with the complications of some of the treatments that we give. They impact quality of life. Side effects track really well with people not taking their medicine. And a lot of times side effects are underreported because we're guilty in the clinic of not asking about them. And I think sometimes people don't tell us. So they don't want us to stop their therapy because they're doing really well. But I think it's something that we need to be thinking about more and more. And I often feel like this, or I used to feel like this. I'm feeling a little bit less like this, but I think, are we able to capture what the burden of adverse events is for patients with myasthenia? Can we measure it in some meaningful way? And I just wanted to sort of put some stuff up here. I don't want to go through these lists of treatment side effects for each particular medicine because I think it would be just too much information. But I just want to show you that for these common medicines that we use in myasthenia, so here's prednisone, which is probably the most commonly prescribed medicine for myasthenia. You can see there's a number of side effects that are potentially associated with this medication: weight gain, high blood pressure, heartburn. And because of that, there are certain things that we should be monitoring in our patients. So we monitor bone density, or we think about people's weight or their blood pressure when they come to clinic, and we monitor them for diabetes. You can see here's tacrolimus, which is another medicine that doesn't get used a whole lot in the United States, but is more common in other countries. And you can see there's problems here. So this is kidney trouble, high blood pressure. You can cause some electrolyte imbalances. And we should be monitoring these some labs in patients regularly when they're on this medicine. And you can see for methotrexate, there are some in here that are specific to that medicine. Mycophenolate, Cellcept, is a medicine that gets used very commonly, and it causes can potentially cause a number of side effects. Diarrhea is common, heartburn. One of the things we monitor for is, are we over suppressing people's immune systems? Are we driving down their white blood cell counts too far? So we screen for that. Azathioprine, another medicine that's sort of commonly used in myasthenia, can cause a flu-like reaction, is associated with some liver troubles. We monitor certain labs with that medicine. And you can see there's the whole list of medicines that I put up for you earlier. All of them have known side effects associated with them that we talk about with patients. And some of them have side effects that we need to monitor regularly with laboratory testing. And of course, these days, when we're thinking about starting medicines for patients with myasthenia, another thing that's sort of entered into that discussion and makes the discussion even more complicated is, what do we do in the setting of a pandemic, and which of these strategies should we be thinking are safer or less safe, or theoretically less safe or theoretically more safe in the setting of the COVID pandemic? And it's an ongoing discussion. And I'm sure, you know, a lot of you have had discussions with your doctors about vaccines, or whether or not you need to change your treatment strategies and other things. So it's very complex these days. And where do these lists of side effects come from? So these are two medicines. So on the right, this is eculizumab, which is Solaris, which is the medicine that's just been approved in the last couple of years. On the left is efgartigimod, which is a medicine that's going before the FDA in December. And when we do clinical trials in patients, we ask both patients who are getting a medication and patients who are not, are they having side effects? And we get sort of these lists of you know, side effects that people have during the trial. In this case, you can see that there wasn't a whole lot of big difference between the medication and the placebo group, and it was sort of similar in the eculizumab trial. So patients in the eculizumab trial, you can see for headache, 16% versus 19%. So these are very similar numbers. And this is one of the ways that we generate sort of lists of potential side effects for patients. And then a lot of these trials, both of these trials, had sort of extensions of the trials where they followed people a little bit longer, and the lists of side effects got a little bit longer for the medications. But one of the reasons why we might start thinking about using some of these newer strategies is if their adverse event profiles are better than things that we're currently using more. Something that I think comes up a lot for patients with myasthenia who are on immunosuppressive therapies are the risk of cancer, particularly cancer of the blood, because when you suppress the immune system, one of the ways that the body fights off cancer is by using our immune system to sort of fight it off. And in this one small trial, what they found was there was a slightly higher risk of cancers of the blood in patients who were getting immunosuppressive therapies versus those that were not. And when they sort of drilled down on it, there were sort of two cancers which were very uncommon in general. So the rates of these things were very low, but the ones that were most common were thymoma, which is a mass that people get in their thymus gland, which is why we get imaging of people's chest when they get diagnosed with myasthenia, to make sure that they don't have this mass in their thymus gland, which requires a surgery. And then there is a small risk of things like lymphoma, which is a blood cancer, if you're on immunosuppressive therapy for a very long time. And it's a very low risk, but it's a real theoretical risk, and it's one that people are worried about. So right now, when we see people in the clinic, it's kind of like somebody comes in, we say, are you having any side effects? They tell us yes. We ask them, to what degree are you having, the side effect of heartburn? But we don't really drill down on it. It's sort of like a snapshot in time, or when we're thinking about comparing medicines, we think about looking at those tables that I just showed you and sort of comparing, well, what does the table look like for Cellcept versus the table for Solaris? So I like to think about it as sort of like a course adjust on a microscope, the big wheel that you turn to sort of start to bring the image into focus. Or if you like sports, I like tennis, it's like seeing where the ball goes the last time somebody hit the ball. Our goal is not to have a course adjust picture of things when we're thinking about strategies for measuring things in medicine. What we want to know is being very specific about what are these side effects, how severe are they, how common are they in the population. You want to have this sort of pictures. This is Roger Federer serving in Wimbledon in 2012, and this is everywhere he served in 2012, and whether or not the person on the other side of the net was able to hit his serve back, and then he can change his strategy. And we're very good at this in sports. This could be baseball, this could be football, this could be soccer. We know stats about everything for sports. We're only just starting to scratch the surface in medicine and catch up and be able to have these pictures for patients that are going to help us have these difficult discussions with all these choices. So what I've been working on, and I'm going to show you some of my work now, is to develop a way to be smarter about measuring adverse event burden for patients. So what we're doing is we're creating a physician and patient derived unit, and we call it the adverse event unit, which is similar to currency. So you could measure adverse events with a medicine like Cellcept and compare it to a totally different class of strategy like IVIG, for example, whose side effect profiles are very different. The type of side effects that we worry about for those two medicines are very different, but we could assign them scores, and we could say, well, you have $10 worth of this, population has $10 worth of side effects with Cellcept, and this population who's getting IVIG has $20 worth of side effects on average with IVIG. So therefore, if we're trying to compare these two treatments, it seems that this medicine, Cellcept, may have less side effects. And that's just a hypothetical, theoretical example. A lot of the units and the ways that we measure side effects in clinical trials right now are physician-derived without patient input. And they're not weighted in a way that you can sort of compare medications from different classes over time, which is the goal of my project. So what we did is we took this thing called the CTCAE, which is used in trials for myasthenia and other disorders, which are just sort of lists of side effects. And we picked the side effects that were most relevant to patients who have neurological conditions, including myasthenia gravis. And we had physicians look at these lists of medicines and different degrees of severity. So you can see here, the first thing I put up here is weight loss. And the first category of weight loss is a 5 to 10% decrease in somebody's weight from their baseline weight. And then a severe degree of weight loss would be a 20% decline in weight and the need for tube feeds because somebody has lost so much weight. And we had physicians that are neurologists, family physicians, pediatricians, surgeons, rate these things and give them scores from 0 to 10 to start to assign weight to these different side effects because they're not equal. So this is a lower degree of weight loss where somebody may have lost maybe 5% of their body weight, but a lower degree of a clot in the body. So this is an uncomplicated pulmonary embolism, which is a clot in the lungs. But this on the CTCAE is given the same amount of points as weight loss of 5%. And these things are not the same. A clot in the lungs is way worse than losing 5% of one's body weight in almost all patients. So we had physicians assign scores. And then what we did was we wanted patients to participate, potential patients to participate in this. So we gave a survey through something called Amazon's Mechanical Turk, which is just a group of people who like to take surveys. And we had them sort of look at two different side effects. So in this case, we described using language that people could understand, pulmonary fibrosis, which is a lung condition where the lung tissue becomes damaged and scarred. And we gave people this very high adverse event unit scored 9 degree. So this is somebody, you develop pulmonary fibrosis and you have 75% of your lung tissue is involved. You have really bad shortness of breath at rest. You have low oxygen levels. And you're starting to get complications from this. It will shorten your life expectancy and it won't improve if you stop the medicine. And we compared that to itchy skin, and we gave people a moderate degree of itching here. So intense, widespread, constant itching as a result of medical therapy. It limits daily living and self-care. You might need some treatment, but it's likely to get better if you stop the medicine. And when we did that, 90% of the potential patients chose pulmonary fibrosis. And what we did is we compared the scores. So in this case, the physicians that weighted the unit gave this a score of 9 and this a score of 6. And the potential patients agreed the pulmonary fibrosis was worse than the itchy skin. And we went through all 73 side effect categories in this way, and we compared things that were scored differently to see if the patients agreed, and almost overwhelmingly they did. But if they didn't, if they thought something was less severe than the physicians, we would decrease the score that the physicians gave it. And if they thought it was more severe than the physicians, we increased the score based on what the patients were telling us. And the goal is to have a list. So this is what we've come up with, and this is under review right now at a medical journal. So here's the complication of high blood pressure. We have different degrees of high blood pressure, and you can see here is sort of like a moderate degree of high blood pressure, which requires starting medications, has a score of 4, versus that pulmonary fibrosis I was just talking about at a moderate degree has a score of 7. So this is somebody who might be taking methotrexate. They come into the clinic and they've developed high blood pressure, and we measure their blood pressure and it's this much. And they've also developed pulmonary fibrosis, and at their visit, they get a score of 12. And what we can do is we can sort of follow this at every visit for patients and score it out over time. And you can get a picture of different medicines. So this is sort of comparing the score of somebody who's taking Azathioprine in red versus somebody who's taking Mycophenolate, which is Cellcept in blue. And over time, if you followed 2 groups of patients for 12 months, the group on Imuran or Azathioprine had a score of 6 per month versus the Mycophenolate group, which had 4 per month. And we'll be able to sort of compare medicines based on their adverse event burden alone in this way. This is just a hypothetical example. We're currently doing this. So our goal is to evaluate this for use in patients with myasthenia. So what we're doing is in 3 separate studies that we're running simultaneously right now, what we're doing is we're taking data from the Promise MG study. I missed Dr. Narayana Swami's talk earlier, but I bet she talked about this trial that she led, where they were looking at the comparative effectiveness of Cellcept or Mycophenolate versus Imuran or Azathioprine. And what we're doing is we're looking at the adverse events that people reported in that trial, where we're assigning them AEU scores, and we're seeing how it correlates with measures of quality of life and other measures. But we're also going to get an early look at the differences between the medicines patients were treated with in that trial with the AEU score. And then we're also going to evaluate the feasibility of getting these scores in our myasthenia clinic at the University of Vermont. So in the first part of the study, what we're doing is we're measuring sort of side effects with the AEU score in patients who have already been part of this trial, which is completed. And we're going to look at it, compare it to other metrics, and then we're going to see if there's a difference between the different immune system medicines that were used in this trial, and hopefully get a picture that looks something like this. And then in the clinic right now, we're seeing how long it takes to administer this unit. Is it feasible to do it in the setting of a clinic visit? And then we're going to see if a score is correlate with changes in people's medicines because of side effects, and how it does versus other measures of quality of life and of disease burden in patients. And then we're going to survey patients and doctors about how useful it was. And this will probably be out sometime in late spring 2022 is my hope. And this is kind of how it works. So somebody comes into my clinic, we know that they're on pyridostigmine and Cellcept, and then we get a list of side effects that would be appropriate for those medicines. And we sort of ask, so this is somebody who's on those medicines and they're having muscle pain, which is myalgia. And they say it's mild, so they get a score of 1 for that. But if they had said it was sort of moderate or severe, they would have gotten a score of 5. If they had itching, we would click yes, and then we would get a list for itching, and everybody gets a score. So right now in our clinic, this is really early data. So we have 16 people in the trial. It's half male, half female, half acetylcholine receptor positive, half seronegative, and people are well represented among the different medicines that we use. So I'm just going to take a stop there just for a second. So that's what I wanted to talk about with adverse event burden. So I think over the next year to 2, we'll have a lot better picture of adverse event burden of a lot of these medicines, and maybe we'll be able to start to figure out which medicines are best from an adverse event standpoint. As everybody does in their talks, this is where I live. This is Burlington, Vermont. And this is the Myasthenia Gravis clinic right here, which has a view of Lake Champlain. So I'm going to talk a little bit about remission at the last part of the talk. So this is a typical patient that I'll see in my clinics. This is a 45-year-old person who has acetylcholine receptor myasthenia. That was bad 7 years ago, had a lot of weakness, was admitted to the hospital, but right now has no symptoms at all, is on mycophenolate alone, and is doing very well for over 3 years. And we give these metrics to our patients when they come into clinic, and this person on their quality of life scale, they click 0 for everything. And when we look at their measure of strength and function, both at home and in the clinic, again, they're scoring 0 because they have no manifestations of myasthenia right now. And so when I see that, I often think about what we talk about as far as prognosis for patients with myasthenia. So I think the first thing that I think is really important to stress for patients with myasthenia is that this doesn't have to be a progressive disorder. This is something that is treatable for most people. And when somebody starts to have symptoms of myasthenia, in large groups of patients, we know that 90% of people who have myasthenia will have their greatest degree of weakness in the first 2 years that they become symptomatic. People are more likely to rapidly progress to that degree, of maximal symptoms in MuSK myasthenia. It tends to have a more severe course, but in general, it's within 2 years. So for somebody who has ocular myasthenia gravis, and it's been ocular myasthenia gravis for 2 to 3 years, it's very unlikely that that person is going to develop myasthenia that involves muscles outside the eyes. It can happen, but it's pretty rare. And when we're thinking about remission, there's sort of research definitions of remission. So this is when we're doing research, we talk about complete stable remission, which means somebody is off of all treatment for myasthenia for at least a year and has no manifestations or symptoms of the condition at all. We have something called pharmacologic remission, which is more common for patients with myasthenia. So that this is a person who has no symptoms at all and has been stable for a year, but they're still taking at least one medicine for myasthenia to stay that way. And then minimal manifestations is not remission. So this is somebody who has no or minimal symptoms, and is on treatment for myasthenia. And when we surveyed our patients, we asked them, so if you're in a prolonged period of remission, how important is it to consider decreasing your medicines for myasthenia? And you can see 85% of people thought it was very important. Another 14% thought it was somewhat important. So overall, 98% of patients that we surveyed thought it was important to some degree to think about decreasing medicine. And 100% of people's physicians thought the same way. And the reason for that is people are worried about side effects, as I showed you earlier. And if people are in remission, do you have concerns about decreasing your medicine? I think this is a very important question. So for patients, about half of the people that we surveyed had concerns about decreasing their medicine, but almost 100% of the physicians had concerns. And if people had concerns, what were they worried about? And overwhelmingly, the thing that people were worried about was having a relapse in myasthenia and developing weakness again. So these are people that have no symptoms or doing really well. Redeveloping myasthenia could be a huge deal for them. And people who are worried about redeveloping symptoms are also worried about things like going in the hospital or uncertainty about the future. So uncertainty about the future is something that tracks very strongly with anxiety, which is a terrible symptom. And the physicians were worried about that too. So people would be sort of anxious that they might have a relapse if we're decreasing their medicine over time. However, I think it's important to know that in these consensus guidelines that were written, so that we talked about the goals of care, and tapering drugs is recommended when people achieve their treatment goals to reduce the risk of adverse events. But in the red box here, tapering immune system drugs is associated with the risk of relapse and maybe require people to go on more medicine. So these are things that, that we're thinking about. So what do we know in 2021 about this as a strategy for somebody who's doing really well? We know a fair bit, so I'm going to skip that. So we did a trial a number of years ago now where we looked back at 4 centers at Duke, the University of Vermont, Mayo Clinic, and the University of Virginia. And we looked at what happened in our patients when we did this. So if we were tapering mycophenolate, which is Cellcept, how many people had a relapse? And the answer was about 30% of our patients seemed to have a return of symptoms. And however, if that happened, if the medicines were increased again, about 70% of those people who had the relapse went back into minimal manifestations or into pharmacological remission again. It wasn't everybody though, but it was the large majority of people would do well if we just sort of put them back on their medicine. The likelihood of not failing the taper, of doing well, was highest if you went very slowly with the taper, so no faster than 500 milligrams per year. So Cellcept comes in 500 milligram pills, so it will be 1 pill per year. And it was best if people had at least 3 years of stability, like the person I just had up in the example. Another group looked at what happens with azathioprine or Imuran. So again, with this cohort of patients, if they were withdrawing azathioprine after somebody had been in remission, this is percent, so 30% of their patients had a relapse. Very similar to our number, 30%. So it's pretty close, and these medicines work very similarly. They didn't look, or at least in this one paper, they didn't look at what happens if the people went back up on their medications. But I suspect, based on our experience with mycophenolate, it would be similar. They would get better. Another group, about a year after we published our study, looked at what happened if people just sort of cold turkey stopped their mycophenolate, so Cellcept. This was people that were either directed to do it or just did it on their own. And what they found is if people just discontinued it, about 3/4 or 76%, 3 out of 4 people would have a relapse. on average, if the person was going to have a relapse, it happened about 3 months after discontinuing the Cellcept medication. So based on this, it's not recommended with the data that we have that people just sort of cold turkey stop it. It's probably better to sort of have a step down approach where you sort of decrease medicine slowly over time to reduce the risk that somebody's going to have a relapse. And what we don't know is if you do that sort of slow decline over time, what happens if you come completely off as you continue to do that slow decline? Will you have this 76% relapse rate, or will it be less if you go very slowly rather than just abruptly stopping the medicine? It's an open question. I think it's an important open question. And as you can see from that paper that we published a couple years ago, patients and physicians other than me think it's an important question as well. So we tried very hard for a few years now to get a study funded to try and look at this question, where we were going to sort of systematically wean different medicines in myasthenia and see what happens until people come off versus not weaning medicines for other people. We got reasonable scores from a couple of good places, but so far this study hasn't been funded. But I hope it will be in the future. We're going to continue to try to get it done. And we had about 20 centers, so probably a lot of the places that you're cared for we're going to be part of this study. So I hope we'll be able to do it and give people more information in the future. So because we haven't been able to do that, I think there's some open questions that we're going to need to answer over the next few years. So will we be able to distinguish among myasthenia gravis treatments in a better way? Are we going to be able to do that with adverse event burden? Are we going to do it based on treatment burden? Are we going to do it based on cost? Are we going to be able to come up with a way where we can sort of weigh all of these things for any particular patient? I think we will be able to. We just have to get smarter about it. And then, is there a better way to guide patients who achieve remission? So are we going to be able to do that prospective trial? Should we look back at our data again and see, answer other questions with data that we already have from people that we follow in our clinic? And how many patients will achieve a true remission off of all medications? These are open questions that I think we need to answer. So I think, just sort of to conclude, I think there's a lot of choices for treatment in 2021. There's going to be even more choices for treatment in 2022 and 23, which is a good problem to have. And then I think treatments are going to be distinguished by the bottom part of the equation I talked about. I talked a little bit about this unit that I hope we're going to start using more to measure adverse event burden in myasthenia. Remission is probably possible for many patients, and I think we need to have an innovative way to look at medication reduction. So thank you for inviting me. Thank you for listening, for the folks that stuck with us. I just have a picture of my mentor, Ted Burns, who's done a lot and has guided me through this and the places that are supporting this work. And this is the reason I do stuff, my two kids. And you know it's COVID because my daughter's got a mask on her wrist right there.
Those masks are permanently attached to our wrists or our car, you know, the gear shift in your car. Anyway, thank you so much. I do have a couple questions here. Regarding, you were talking about a study, and it was just before you showed the picture of Lake Champlain. This person wanted to know if they could join that study now.
This study?
Yes.
Only if you come to my clinic.
Okay, there you go, Neely. You have to go to Vermont.
Yeah, Vermont or upstate New York right now, but it will be coming to a study near you if this is successful over the next year.
Okay. All right. A couple questions just regarding side effects. This person had said that they had bladder symptoms with their MG. When they have a severe exacerbation, that's 2 or 4 times a year in the hospital, they can't empty their bladder. They realize this is supposed to be impossible, but it only happens at the peak of a bad flare. They're also seronegative. Do you have any theories on that?
I don't. hard to answer specific questions like that, not knowing everything about somebody's medical history. But I mean, there are immune system reasons why people can have trouble with their bladder too that are not myasthenia.
Mm-hmm.
I mean, it's just important for your doctors to sort of think broadly, I think, when you come in.
Okay. How do you think those involved in FDA, healthcare, drug development, and manufacturing community could do more as far as not only monitoring for, but finding out more information as to how to treat or prevent potential short or long-term side adverse effects caused by these therapies?
Yeah, so I think, as I was trying to get at, I think we need better tools in our box to do that. I don't think we have a great toolbox to do that for any condition, really. I think it's a big need. You know, we think about a lot of things. So there's certain things that are very easy to measure, right? So if you're giving people a treatment and their life expectancy goes down, that's pretty easy to measure, right? And it would be bad if people were taking the treatment and more people are dying to take that treatment. That's really easy. That's low hanging fruit. The FDA is very good at monitoring stuff like that. I think people do use these scales, like that thing called the CTCAE. I think we're very good measuring that, but it's not something that's designed to be followed over time. It's sort of designed to be followed in a clinical trial to be like, you know, oh, we were measuring this medicine and a lot of people had a moderate degree of headache in the treatment arm. So we know that that's a side effect that people get. The other thing that happens outside of trials is sometimes if a lot of people are getting a certain side effect with a medication, there's a reporting system that patients and doctors can use through the FDA to sort of report, like, you know, a lot of patients who are getting medication X are having really bad muscle pain, which was not something that we observed in the trial. And they kind of keep track of that. And then eventually, if enough of those events are reported, it sort of starts to populate in these databases that we look at to look at what are the most common side effects associated with certain medicines. But I hope by keeping score in trials with units like mine, I think we'll be able to be a bit smarter and help that.
Okay. Someone typed in, and we might need to go back to your slides. They say, what were the tests to monitor the side effects for plasma exchange? The slide just changed before I read the recommended tests.
I saw that one come up and I was way past it.
Sorry. I meant to catch you when you took that little slight break and I didn't.
Yeah, so, and I wouldn't, so a lot of this is stuff that when people go in for plasma exchange, so plasma exchange is it can be used in a chronic way where people will come in like once a week, but it's more commonly used if somebody comes into the hospital and is having a big problem with myasthenia, because it's a very successful treatment. So a couple of the things that are on the list for plasma exchange. So plasma exchange, I don't know if somebody put up a picture of what that looks like earlier. Did anybody put that up, Nicole?
I don't recall that.
Yeah, so plasma exchange, the machine that does it looks a lot like a dialysis machine.
Okay.
And plasma exchange, what we do is we pull people's blood out through a catheter and it goes into this giant machine. And it takes plasma, which is the fluid that bathes your blood cells, and it throws it away. And then we give people back fluid with some protein in it called albumin is how it's termed, with their blood cells. And then we pump it, your own blood cells, and we pump them back into the body. The reason why this is helpful in myasthenia is because antibodies, which cause myasthenia, live in the fluid that bathes our blood cells in the plasma. So we're throwing away the antibodies when we do that. But when we do that, we're also throwing away a bunch of other stuff too. One of the most important things we're throwing away when we do that is people's clotting factors. So the things that when you get a cut will help you clot the cut off so that you don't bleed to death. We throw those away. It takes about 24 hours to regenerate some of those. So usually if somebody's getting a course of plasma exchange, they don't get it any more frequently than every other day. And it's because of that side effect. And then there's some metabolic shifts that can go on, but the people who manage plasma exchange are either nephrologists, so kidney doctors, or hematologists, blood doctors. Depending on where you are, it's different in every place. But they kind of monitor this stuff behind the scenes. So you may not even know that they're monitoring it, but they usually monitor it in the place where you're getting this treatment.
Interesting. Okay. Thank you for explaining that. That's interesting. We have a question from Jacqueline. I'm sorry if I mispronounce this. Azathioprine? Azathioprine?
Yep. So azathioprine or Imuran.
Okay. If that takes minimum of 6 months or longer to initially kick in, and someone is able to taper off due to remission, if they have a relapse and have to be put back on it, is it going to take 6 months to kick in again?
That's a really good question. I think it's an open question, but in theory, yes. So, and the other thing that's interesting about when you come off a medicine like azathioprine, or I'll talk about azathioprine and Cellcept the same, because they're very similar the way that they work. And that thing where it takes a minimum of 6 months or longer is true for Cellcept as well. So with both of those medicines, it can take a long time for them to kick in, but also as you take them away, the effects of those medicines last longer than a few months. So what we found in our study was we would sort of decrease the medicine, and if somebody was going to relapse, it could happen 6 months after you make that change. So that's why, based on our study, which I'll put back up, we don't recommend decreasing it any more frequently than every 6 to 12 months because of that. So no faster than 500 milligrams every 6 to 12 months. In the study, we recommended 12 months, but I've been doing 6 months with patients and it seems to be okay. And in my experience, it doesn't necessarily take 6 months for people to get back to doing well, but in theory, it could take 6 months.
Okay.
In a bad relapse, you may need to add something else. Like you might need to add prednisone back, or you might need a short course of some other treatment if you had a really bad relapse. But that's not what we observed. Most people just sort of got back to their good status if we put them on their medicine.
All right. I don't see anything else that has popped up. Thank you so much for your time today. It's definitely appreciated.
Thank you again for having me. I hope some people learned something today. Take care.
Yes, they enjoyed it so much. Thank you.